Wanted to welcome everybody to the 2021 Advanced Health Plans User Group meeting. We appreciate the investment and the interest in learning about the bank's health plan. As always, this meeting really is powerful because it's interactive, and so if we have any questions that come in remote or here in person, we want you to just go ahead and raise your hand and send in a question. I'm Jay Kempton. I'm the plan administrator for Advantage Health Plans Trust. I'm hired by the bankers to administer and run the day-to-day operations of the health plan, along with an incredible team that I have at the Kempton Group. Got with me Melissa Nance, which is our Chief Brand Officer here at the Kempton Group. Say hello.
Good afternoon.
And we're going to kind of be stepping through this agenda. We're going to try to be disciplined because we have quite a bit of information here. We want to try to make it as simple as possible, but there is a lot to it. We're going to try to do it in a concise and organized way. We're going to break the meeting into a few bullet points here from an organizational perspective. We're going to be talking about performance and reporting. We're going to have an update on COVID-19, which I think we can all look around in our day-to-day lives, including this meeting, and kind of see some of the results of COVID. We probably have 90% of the attendees here for this meeting are remote, but we appreciate y'all that have rolled out in person. We really do. Socially distance appropriately, it looks like. Then we're going to talk about 2021 drug performance, or the prescription program as part of Advanced Health Plans. I do think that a lot of our bankers, we kind of discount or don't really think about prescription drugs as being a huge driver of our health plans contributions or what we pay in premium into the health plan. But I'll tell you, it is a bigger and bigger component. It's upwards of 30% of the total claim spend for Advanced Health Plans is prescription drugs. And then always the big attraction for this meeting is where we'll give everybody here in attendance kind of a sneak peek to the 2022 renewal. We're also going to be talking about some 2022 just plan changes. We're going to talk a real quick compliance update and introduce another meeting that we're going to be having that's going to be dedicated to compliance. And then Melissa's going to talk a little bit about the AHP team that is dedicated to Advanced Health Plans from a support perspective. When you as bankers or any of your employees have any questions or need any assistance with anything, we're going to kind of go through the team that is set up to support our banks. And then lastly, we'll go over the open enrollment timeline. Like we talk about every year, Advanced Health Plans is a unique program in that it is partially self-insured, it is not-for-profit, and it is actually governed by a board, an elected board of trustees, all bankers. We have quite a few of our trustee bankers that are actually here in attendance, but these are the folks that I work for. Melissa and I, we make recommendations to the board, and sometimes they take our recommendations, and sometimes they go in a different direction, which is exactly what the member banks expect out of their peer bankers. So we appreciate the work and the time that this board of trustees puts in to running this health plan. It is certainly not an easy task these days. The very first section, we're going to spend just a little bit of time going over some 2021 successes and celebrations. Kind of start off on a positive note. Not that there's anything negative in the meeting, but there certainly are some certainly bright spots that have occurred here in 2021. Melissa, you want to kind of step through some of the new relationships that we formed?
Yeah, I like to start out our conversations talking about celebrations and successes. I kind of also think about it a little bit as a year in review. I think that in most of my conversations with the banks, I would say that you all are usually holding us accountable to improvement, enhancement, evolving, et cetera. And one of the areas that you all hold us accountable to do that is in our provider relationships. So we did want to sort of give you an accounting of where we're at throughout the year, or at this point in the year, of the providers that we have added so far in 2021. If you are signed up to receive any of the announcements that come from us via email, and you might be signed up to receive them, but might not be getting them. So I would recommend whitelisting us in your inbox to make sure that these get delivered to you. But we do try to announce these periodically throughout the year as they happen, because we hope that you'll be able to utilize these providers. But we have got several new relationships. You all are familiar with kind of our premier product or service that we typically talk about because it's the one that usually saves everybody the most amount of money, both from the plan's perspective, both from the employer's perspective, and also on your employees out of pocket. That's the Kempton Premier Provider Program, or you might hear us abbreviate that as KPP Free. So this year, we've actually engaged in new provider relationships with 15 KPP Free providers. They're in a number of different locations, and actually in the handout that you've been provided, we've listed who those providers are. Those providers are also accessible on our website, and then also our Kempton Care Advocates in the office in our call center can assist you with navigating to those providers. The second one that's listed there is KPP Free Aggregators. So let's talk about that a little bit. Some of you might have heard us use the phrasing MD Save. And the reason that we wanted to go over this a little bit today is because we know that there can be an alphabet soup, a lot of acronyms, a lot of different phrasing and words, but we want to make sure that we're always updating you. And so this last year, we had an opportunity to enhance the KPP Free Provider Program with a number of providers through an MD Save partnership. So that doesn't really need to signal anything to you. You don't have to do anything even differently. All you need to know is that we have about 177 additional providers that we've added as a result of having the relationship with MD Save. When you call our office, or whenever your employees call our office, we are working to look at the providers that are participating with the KPP Free program through MD Save the same way we would any other Kempton Premier provider. So they're all sort of in the same resource toolbox for your employees to be able to utilize to have services or medical procedures through the KPP Free program. But you might see some branding on vouchers or emails, or you might even hear us slip into the word MD Save. And so it's important to know that. But primarily the areas where we added a significant number of those 177 is in the Texas area, and then also in the Southern Oklahoma area. So some big opportunities for improvement there and more increased access to KPP Free providers. The next one on the list there is KDAP. So you all heard an update about 2 years ago regarding the KDAP program. That stands for Kempton Direct Access Providers, and that's the benefit that the trustees chose to add to the plan about 2 years ago to allow a subsidy to be paid to a direct primary care provider for participating enrollees in that program. And that subsidy covers all of the medical care that an individual would receive from that provider on a monthly basis. So that's a direct primary care provider. When we rolled out the program initially, you all might remember that we had Primary Health Partners here at this meeting about 2 years ago, introducing the concept of direct primary care and also what that benefit was like. Since that time, we've added a number of different providers, and in 2021, we've added 4 additional Kempton Direct Access providers, so employees have the option to enroll in that benefit in a number of different locations. So I think we're totally now up to 6 providers participating in that program, and one of them is in Fredericksburg, Texas, and has got a little bit of enrollment in it. So that was a big celebration for us. And then the last one there, we did spend quite a bit of time talking last year and also the year before about reference-based pricing. You've heard us add a couple, we've added some new benefits. We've changed out-of-network benefits. We've talked about some of the value proposition of reference-based pricing. Y'all might recognize the name of the plans that use reference-based pricing as the choice plans. So anytime you see any of the plan designs that come out that have choice, that is the name that designates that those plans don't have a network, they actually replace the network utilizing full reference-based pricing. So we oftentimes try to work with providers in another direct relationship so that we can engage in a contract with them, an agreement with them, so that any of the services that are done by your employees or their dependents at their facilities are held to a reference-based price under a contractual relationship. There's a benefit to that. And the reason that there's a benefit to that is because there is a mutually agreed upon price under that direct relationship, and it does not result or it prevents any potential for balance billing. So it's a win-win for employees. It's a win-win for the provider. It's a win-win for the health plan, all the way around. And those kind of contracts are becoming more and more prevalent because they're very beneficial all the way around. So we've got 22 additional contracts that we've been able to add to our arsenal to assist employees with directing to providers that are offering, quality care at a valuable and reasonable price that's knowable up front for a fair benefit under the health plan.
Yep, that was great. That's a great update.
Okay, the next sort of celebration that we wanted to just talk to you briefly about, I hope that you all have experienced what I'm going to call an upgrade in our call center over the last year, because we have been working very diligently, not only from a staffing perspective, we have had some growth within our company, and so that has caused us to need to invest in the infrastructure of the employee base at our company. So we have done that by hiring some additional customer service representatives. We call them Kempton Care Advocates, or you might hear us abbreviate that as KCA.
Because we need one more abbreviation.
Another abbreviation to add to the list. So our Kempton Care Advocates are the folks within our office that work with the individual employees as well as their families, their dependents, to assist them with understanding what their benefits are, and to help them navigate to providers that can give them access to free market healthcare, or at least fair and reasonable pricing for their healthcare. So one of the things that we did this year is implement a standard within the call center where we would be elevating or enhancing the amount of education that every member gets when they call into our call center. So typically when we think about education, we think about that from the perspective of the employee meeting that we do when we go out to the bank. And so when we're at an employer and we've got a room full of employees, we're doing an educational session, and we're talking about what drives the cost of healthcare and how does the benefit interact with that, and what can you do differently, and how can you be informed to be able to make good choices to be in control of your healthcare. But in the call center, those conversations are a little bit shorter, because oftentimes the participant that's calling, or the member that's calling us, has a specific question. They have a specific provider. They have a specific need with a specific medical service or situation that's happening where they really just want an answer for that particular thing. And that's okay. But what we've identified is that there is an increased opportunity for some more education outside the enrollment meetings, outside the educational meetings. And we have an opportunity in real time to interact with your employees on a real-time basis and make an impact in their lives from an education perspective. So we spent a lot of time at the very first of this year going into the second quarter, preparing and setting standards, and even implementing some scripting in our call center to make sure that standard of care and standard of service across the board is held to an excellent standard. And we've gotten a ton of positive feedback. So the thing that I want you to know from this conversation is that anytime a participant calls into our call center, we are going to be going over with them two things specifically. Number one, we're going to do a cost disclosure. And what does a cost disclosure mean? What that basically means is we're going to go through the tools that we have access to help the participant understand what is the actual expected cost of the medical procedure or service that they're anticipated to have. So it's possible that they're calling us for a chiropractic visit or a physician office visit, or it's possible that they're calling us because they've been ordered to have an MRI or some other type of diagnostic imaging, or perhaps they have actual orders to have surgery. Whatever the case is, the reason that they're calling us, our goal is to make sure that everybody that calls into the call center has real information about where they live or where they're seeking care in their geographic region, about what they can expect and anticipate that the cost of that that particular medical service would be. Now, you all might be familiar with Healthcare Bluebook because that's one of the tools that you all have access to. It's one of the tools that we have access to help give us that cost information. But we're actually going through a live search with the member on the phone to help them understand that that procedure or medical service has a cost attached to it, and we do that cost disclosure. We view that that's actually a very foundational principle to the rest of the conversation, which is now you know what the cost of that care is. Now, what do you do about it? And where can you go to get access to fair cost surgeries or other medical services? So the second thing that we do in our call center on every call is what we call a benefit disclosure. And so what that means is we're just taking what the cost of the procedure is that you've just told us that you need, and we're comparing that against what is the benefit that's available under the plan. So we want to make sure that everybody has a clear understanding of what their out-of-pocket cost might be. If there's any potential limitations or exclusions that might affect that potential procedure, we want to make sure if there's any frequency limitations or anything like that, that everybody is just clearly understanding rather than having to look it up in your summary plan description, which is 175 pages long, that they're getting a better description and summary for how that benefit applies in those particular situations. With those two pieces of information, what we're also finding was an intended consequence, and it's working, is that the incidence for helping people, once they understand what the cost impact and the benefit impact of those two things together is, they're more successfully, more frequently utilizing Kempton Premier providers and other free market value healthcare providers. And so our success rate for being able to, what I would call intervene in those situations is going up, but our satisfaction rate is going up as well. So we have gotten a ton of positive feedback. I'd love to hear positive feedback from you all, and I'm saying that intentionally because I don't want to hear any of the negative feedback, but we've gotten lots of positive feedback from everybody and really appreciate the opportunity. But we have invested in the infrastructure of the call center and increased the number of staff that we have available so that we can engage in those more meaningful conversations when your members call us. The last couple of things I'll mention about that is just Healthcare Bluebook and KPP Free Education and Redirection. I mentioned that you're familiar with Healthcare Bluebook. There was a change that happened this year. We'll talk a little bit more about that at the closer to the end of the presentation. But I think you all probably at this point have seen the communication that went out. It's been probably about 2 weeks ago now, where there is now an emphasis on the actual searching of Healthcare Bluebook, using that as a tool in order to be eligible to receive any type of cash reward or green reward is what it's called under the plan for using green providers. So like I said, we'll talk a little bit more about that at the end, but the enhancement that we've done in the call center is that typically we had access from our side to utilize Healthcare Bluebook when your members contacted us and to walk them through that search. So we had the resource, we had the tool available, but it was with our own accesses. What we've sort of improved and enhanced a little bit is that we're now utilizing the member search tool and helping them to understand the instructions for that self-service tool, which also impacts that requirement for them to engage in that search process to be eligible to receive those rewards. So that's been an enhancement as well. And then finally, we're always looking for opportunities to be able to increase the value of the KPP free providers and to find places where members can have cost-effective healthcare. That's just what we're always looking to do. And so we've implemented some standard processes in our call center to be able to evaluate when something is not necessarily as clear cut as we've got a provider, we've got a procedure, and so we're going to send a voucher. There are some more complex situations. And so we've really invested in trying to enhance that process to make sure that even in not clear-cut situations, even in situations that require a little bit more of a handhold, we've got a solution for those. And it's resulted in some pretty creative situations that have been a big financial impact to our members and to the plan. So we're happy about that. I'd love to talk to you all and get some feedback from you all. The number of incidents that we see where, I've even been involved in a couple of situations where somebody has sent a basket to our office, thank you notes to our office, just telling us how much they appreciate the care and the service that they feel like they're getting. And so that for me, obviously, is a big reward. And we just appreciate the opportunity to be able to provide that service.
Yeah. It's been very, very exciting and fun to watch for sure.
Okay, the next one that I want to talk about is the addition of another person to our team here at the Kempton Company. Some of you all might have met her whenever you came in, and you might have even talked to her in the last 2 days in anticipation of this meeting. But Isabel Kempton Moore has just joined the Kempton Company and came to work for us this week. And so this is her debut meeting at the annual...
Second day on the job.
Yeah, second day on the job at the annual Advantage Health Plans user group meeting. So we wanted to introduce Isabel to you all and kind of let you know a little bit about what her role will be at the company. Isabel's official title is a human resources specialist. So Isabel just graduated from Oklahoma State University in human resources management. And so she's got a minor, I believe, in accounting. And so what she brings to the company, which I think works really well for what we are doing for our clients, is a human resources background with a specialization in benefits. So what she's going to be working with us on throughout the rest of this fourth quarter through January is working with our banks and working through this renewal season process to get everybody on a plan to have whatever plans you all want to renew with, have those renewed. So she's going to be very involved in maybe even employee meetings, talking to you about what plan options are available, maybe talking to you about renewals. She'll be working with us to do that. And then after the first of the year, we'll sort of be branching out to some additional things that she'll be involved in with our company. But she's grown up around employee benefits and the Kempton Company, been very involved in the Free Market Medical Association over the last several years, attended several of the conferences with us. She even recognizes and knows some of you all just from being around. So we're glad to have her on board, and she's gonna, you might hear from her a little bit more over the next several months. So welcome, Izzy.
This is, as Melissa was talking about, the KPP free redirections. I want to remind you all that there's a large amount of market-based economics that are that is taking place at the same time. I know that your employee when they need their gallbladder out or whatever else, they're not thinking about the economic impact or any sort of market alteration when they're calling us up and saying, hey, I need to have my gallbladder out. Who do you recommend? But I will tell you that the medical community at large around Oklahoma, around Texas, and around this region of the country, they are definitely taking notice. They definitely understand what is happening, and they are starting to see more of an expectation of being competitive, not only from an outcome perspective, but also from a dollars and cents perspective. That did not happen 10 years ago. And so this is just a real quick success story that I wanted to share with the membership, because it does kind of illustrate the power of what we're all doing. And when I say we, I mean we. It takes every single banker in this room and every single employee to kind of change the way a market works. And so this is a scenario in which we had an employee that did not call in advance. They just went where their doctor told them to go, and ended up going to South Texas Spine Hospital for a knee replacement a few months ago. Sometimes we get a lot of heads up on these, and sometimes the first we hear about it is when the claim rolls in. And this was one of those situations where the claim came in. That was kind of the first we were aware of this. Claims, once they get into six figures, they'll generally hit my desk or Melissa's desk, and we'll take a look at those. This one kind of really jumped out at me because, we do a lot of knee replacements, in Advantage Health Plans. And when I see $144,000 knee replacement, which we're used to paying $25,000 for it, that kind of raised my eyebrows a little bit. The bill charges from this facility, which I had never really heard of South Texas Spine Hospital at this particular time a few months ago. The bill charges were $144,000. The PPO allowable for this banker's network reduced that charge down to $58,000. Being that there was an implantable device that was in this claim, as you all will probably remember, for implantable devices, Advanced Health Plans has a limit, and that is whatever the medical provider paid for that device plus a markup of 100% is all that the plan is going to pay. And on this particular one, we were able to look at this and say, wow, this is a member that if this medical facility does not provide us with a purchase invoice and we have to disallow the implant, and if they go after the patient, this could be a huge financial hit to this particular employee. So as we're kind of discussing this, I decided, well, I'm just going to Google these people, and just got out my browser. South Texas Spine Hospital popped up. As soon as I clicked on the link, right across the top banner of this medical provider's website, it said, proudly physician owned. Like, okay, so we have a physician-owned facility that is gouging us. I know a little bit about physician-owned, surgery centers, so I'm going to give them a call. They actually had the name of the CEO was on the website along with the phone number. I called her up, and after asking the first person that answered the phone if I could talk to the CEO, next thing you know, CEO is on the phone. That does not happen very often, but it did happen in this situation. I told the CEO the situation. I said, hey, this is an in-network claim. You by rights are entitled to your $58,000, but you need to be aware that this plan is not going to pay the entire implant charge. Kind of went through all of that. And I said, you are a physician-owned facility. We kind of pride ourselves on partnering with physician-owned facilities. I know you and I have never met before, but I said, we could really help this banker, and we could really help the banker's health plan if you would be willing to match a price of one of your competitors. I said, we have lots of medical providers around Texas and Oklahoma that offer bundled pricing for orthopedic procedures. And her comment was, oh, bundles? We do bundles. I was like, well, I didn't see them on your website. She goes, well, you have to ask for them. I said, well, I'm asking. And anyway, it took about 2 weeks to do, but we were able to actually get that medical provider to retrospectively match the price of a Kempton Premier provider. We're in the process right now of contracting with that provider to bring them in as a Kempton Premier provider. But my point is that if it wasn't for kind of a veiled threat of mine that, listen, this might be the last case you ever get because we're going to talk to our bankers that, hey, you're a bad place to buy healthcare. But this particular provider looked at that as an opportunity to forge a relationship with our bankers. And so kudos to South Texas Spine Hospital, but we ended up getting that down from $58,000 to $26,000 with just a couple of phone calls. I don't know that the participant knows anything about this other than they don't have a big giant balance bill and they didn't have to meet their deductible. But that's the backstory. If this participant is listening, that's kind of how this all went down. The next, also under successes, is VASA Health. I don't know if anybody in this room has heard of VASA Health. If you're a board member, you don't need to raise your hand because I know you all know about it. But VASA Health is a pilot program that the Board of Trustees implemented earlier this year. And what VASA Health is a remote second opinion program for high dollar, high complexity medical conditions. It's been something that we may or may not be very aware of at our bank, but there are a lot of individuals that end up getting either a bad diagnosis, a misdiagnosis, or individuals that are referred to a particular medical provider for care in which that particular medical provider that they were referred to is really not an expert in their condition. And sometimes they just kind of wallow in poor outcomes and poor care. We recognize that, and we had located a vendor through some different industry connections. We found VASA Health. What they do is they will scour claims data, our claims data, on a de-identified basis, looking for people that maybe have a particular condition Maybe they've had this condition for years and years and have been having multiple claims on it. But this is a condition that you should be over in about 6 months. And so they see it as drug on and on and on. That might be one that they say, I think it'd be time for us to, and again, they're a team of nurses, that they would call up this participant, ask some questions, and if possible, they would get them a remote second opinion with a medical expert in the particular field of care that patient has a need. And it would be a remote second opinion, maybe with a physician from Johns Hopkins or from somewhere around the country. We were a little bit skeptical as to the actual results and also how our bankers would react to that type of intervention. And so the trustees basically allowed for, again, a pilot of 10 patients. And so it took us a few months, but eventually we, looking through the claims data and then also looking through just some referrals through Kempton Care Advocates, we ultimately found 10 participants that needed some additional navigational tools to help with their conditions. And the results are here on the screen. They have outreached. They outreached to 61 members that were on their target list. 10 of the 61, remember they only had 10 spots available, but 10 ultimately engaged. Of those 10 patients, there were 6 remote second opinions that were completed. 4 remote second opinions are still pending. The total hard dollar savings to the plan, and this is really about right-sizing their care, maybe getting them to a different medical provider to take care of their needs. The hard dollar savings is $225,000. Again, this was from April 1 and only on 10 patients. Hard dollar savings of $225,000, a risk negation of $225,250. And that is simply, we had one individual that was getting worked up to start treatment for multiple sclerosis from a local physician in a rural part of the state. Ultimately, this patient didn't have MS. They had carpal tunnel. We were able to get them to a physician. They were re-diagnosed and was able to have a surgery. I mean, the complications regarding being treated for MS when you don't have MS are not only are the hard dollar costs, but also the condition, the health problems that would have created. Those kind of things happen all the time. Anyway, so only banks that had one of these 10 individuals in them are aware of VASA Health. But right now, because of the results since April, the board has gone ahead and approved for VASA to provide a proposal to expand the number of slots beyond the 10 and look at a potential full engagement with Advantage Health Plans. This is not something that as an HR professional, you all need to do anything necessarily other than educational material, assuming that the board moves forward with a full engagement. But this is one of those things that if you don't need this type of assistance, you won't ever get a phone call. But if you do, and it's completely voluntary. But these are some really special types of interventions that your board and your administrator is looking at on a continual basis to try to help bend that cost curve and have healthier bankers at a lower price point. Any questions or comments about VASA? There's no cost to the bank. There's no cost to the employees for this. This is simply a value add. Okay. Now on to performance and reporting. You do have your meeting handouts. Really, everything that you're going to see on this slide presentation is here. You actually have a few performance reports that are not going to be on the screen. Those will be for your own review when you get back to the bank. But we're going to step through not only performance metrics, some of the reference-based pricing metrics regarding balance billing, direct access provider relation, enrollment, KPP providers, et cetera, et cetera. The first slide here is really just medical and prescription drug costs going back to 2016. Blue are the medical claims, and the light blue are the prescription claims. You can kind of see how things were going from a claims perspective back in 2016, 2017. We started to see an uptick as far as medical claims were concerned in RX back in 2018. Nothing out of the ordinary, though. By 2019, we saw a pretty significant shift where we actually started to burn some surplus. If you all will remember, we actually have a graph coming up here that kind of shows the different rate adjustments. But back in that 2016, 2017 period, we had very, very low adjustments. I think we had a year or two where it was almost no adjustment at all. This is why. In 2019, we saw a pretty significant uptick. 2020, of course, we all know what happened in 2020. That's when we got the first big wave of COVID claims that occurred in July of 2020. And then we had the next big wave of COVID-related claims that happened in January of 2021. This chart does show these medical claims on a fiscal year basis, so July 1 through June 30. And so even though 2020 shows a dip, the big bump of claims in July of 2020 and then January of 2021 are all on that 2021 column. But seeing it like this, you kind of get a feel for how things have changed just since 2016 as far as the medical claims are concerned. So I hope also that you see, when we see this, we do react and try to aggressively manage this. The days of just rolling, rate adjustments out and just letting the chips fall where they may are really over. We do try to battle healthcare cost increases on both sides of the equation. Not only, unfortunately, sometimes we have to do it through rate, but we also try to do it through, again, steerage of medical providers of our patients to higher value medical providers, and then also hopefully right sizing the care is also a tool that we use to help mitigate some of these increases. Some of the KPP reporting, you all see this chart every year. I'm not going to step through all this, but I can say over there on 2021, this is from January to June 30 of 2021. We are on track for more KPP procedures. Actually more dollars saved. If you were to annualize this, we hopefully will be on track for close to $6 million in direct savings from utilizing the premier providers out there. We are still seeing a good number of cash price agreements where a patient is requesting that their medical provider match a price of a KPP, even though their medical provider may not be transparent with their pricing. We still have bankers that are requesting that, and looks like we're probably, if we were, being that we only have 24 so far in the first 6 months, probably going to be under on cash price agreements, which is not necessarily a bad thing because we do have a lot more premier providers out there. So statistically, there's probably less of an opportunity for a price match if they've already come our way. Any questions on these? Okay. Missed opportunities. Not going to read these, but missed opportunities, we are doing a lot better as far as missed opportunities in the first 6 months of 2021. We are on track for, hopefully probably more than $1 million less of missed opportunities in 2021. So again, pat yourselves on the back with that. We're seeing a lot more price awareness and price consciousness coming from the employees and their dependents. Also, I think that Melissa's comments about the cost disclosures and everything on every phone call, I think that is also contributing to a reduced number of missed opportunities. KPP Free Savings by year, this is going back to 2012. You can see how the program has grown in the number of services and also the dollars saved versus the utilization of just the standard PPO pricing. Top savings by category. We're actually seeing, oncology now is the number one category. It wasn't too many years ago where, it was orthopedics and imaging. But we are seeing a lot more utilization of cardiac providers that have decided to be upfront and transparent with their pricing, as we've also seen a lot more on the oncology side, where oncology providers are starting to really step up and offer upfront pricing. Reference-based pricing for the choice plans. We're not going to be emphasizing reference-based pricing at this particular user group meeting. I think we hit it pretty hard the last 2 or 3, but we did want to at least include one slide on how the balance billing, because that's always the risk, right? If you go with a plan within Advantage Health Plans that doesn't have a PPO network, you always run the risk of a medical provider not accepting what the plan pays and then sending a balance bill to the patient. So from January of 2020 through July of 2021, on the Advantage Health Plans choice plans, we had just a hair over 17,000 claims that were submitted. That represents about 3,000 belly buttons that actually had those claims. Those 17,000 claims, 20 of them were balance billed. That's 0.12% of those claims resulted in a balance bill. Of those, 14 were resolved positively. And when we say resolved positively, either the medical provider wrote them off after having a discussion with them that what you were paid was actually fair and reasonable, or the plan may have had to negotiate with that medical provider and kick in some additional dollars in order for the medical provider to see that as paid in full. The average percentage above the medical provider's Medicare payment that resulted in the bill being written off, the average negotiated percentage above Medicare was 146% of Medicare, which is great. I mean, we're by default, we're paying most primary care physicians at 130% of Medicare. We're paying most hospital bills at 160% of Medicare. So the average negotiated amount was 146%. It's wonderful. Total billed charges on these 17,000 claims was $19 million in billed charges. The plan didn't pay that, obviously. We did pay it under the Medicare reference base amounts, which made the plan payment $6.3 million, saved the plan about $12.7 million on those claims, or 67% off of the billed charge. Most PPO networks we see, they are negotiated as opposed to from a baseline up, like Medicare Plus. Most PPOs are done on a percentage off of the top, off of whatever the medical provider bills. And we usually will see those percentages somewhere in the 30 to 50% range. Again, Medicare Plus is providing 67% off the billed amount. Melissa mentioned about the Kempton Direct Access Provider, the direct primary care subsidy that's available under Advantage. We've started to see more and more growth in that. Direct primary care is still in its infancy in the country, but it is growing very, very rapidly in the different metropolitan service areas. Unfortunately, we don't have a ton of banks in Advantage Health Plans that are in the metropolitan service areas, so it does create a little bit of a gap there. But some of the new ones, Mid-Texas Direct Primary Care in Fredericksburg is a new direct primary care clinic. They have 3 enrollees down there. Primary Health Partners is based in Oklahoma City, but they have, my goodness, I think they have 3 direct locations and probably 20 affiliates now around the region. But they have 113 bankers enrolled. Reliant Direct Primary Care, 5. Remedy Direct Primary Care has a few locations in the Tulsa area with 40 bankers enrolled there. and then 2 other brand new ones, Direct Primary Care of Oklahoma and Simple Primary Care Solutions, also in Oklahoma. I would encourage any of our Oklahoma and Texas bankers that if you hear of a new direct primary care clinic that's going in your community, we may not be aware of it. So please send us an email, call your Kempton Care Advocates. Let us know about the existence of those folks, because we will certainly reach out to them and just see what type of a direct primary care facility they may be. If they are one of those that is willing to play ball with an employer-based plan, then we will certainly put an agreement together with them. Not all direct primary care physicians want to play, though, with insurance or with employers. A lot of them only want to do business directly with the patients, which I don't blame them. Honestly, a lot of them have been burned by the insurance companies through the years. That's why they're a direct primary care physician now. Really kind of a summary slide of showing Advantage Health plans in 2020, and then for 7 months of 2021, the actual paid medical claims in dark blue versus what the actual paid medical claims would have been if we did not have the benefit of the reference-based pricing programs that we have, and or the Kempton Premier providers. It's pretty easy to see what a hip replacement is costs when you use a Premier provider, again, because the pricing is up front, it's transparent. And then we also know what generally the networks would price that same claim at, and there's the differentials. They're pretty substantial. Melissa and I are working on these slides every year. We want to always paint a positive picture, but we also have to remind our bankers that healthcare is expensive, and not everything can be redirected, and not everything can you shop for. We see a lot of claims. It feels like probably the last, maybe it's just that we're more attuned to it with COVID, but we do look very closely at these large claims. Once they get into 6 figures, they are something that we really kind of black box and look at them and say, is there anything we could have done differently? And I will just tell you, and I hope that there's nobody that is on the meeting, but there very well could be, that's been impacted by some of these. We've had some really horrible claims. We really have some situations that you hear about the diagnosis, you hear about the treatment, and your heart just goes out to that member and to their family. This is not to belabor or to be morbid or anything, but these are the top 5 claims from a dollar perspective in the first 7 months of 2021. The largest one was an emergency cardiac defibrillator implant. The bill charges, if I can read that, $384,000. It was a PPO plan, so the PPO allowable, or the discounted amount, brought that down to $249,655, and that's roughly what the plan paid, because by that time the member had already met their deductible and already met their out-of-pocket max, and so the patient's responsibility, as you can see, really was a non-event. Didn't have any impact on what the claim, how the claim was ultimately paid. But just for reference, pardon the pun, but you can see the Medicare reference-based pricing allowable for that same claim was at looks like 109 versus the 249. The second one was a soft tissue carcinoma, or excuse me, sarcoma, which is a cancer of the soft tissue of the abdomen. $339 was the bill charge. Plan paid $254. The third claim there was actually acute respiratory failure with pneumonia. It was a COVID-19 claim with one of our bankers. Bill charges of $262,000. Paid amount from the network allowable was $150,000. The plan paid $145,000. So the difference there was the patient's responsibility. You can see also what the Medicare reference-based pricing allowable would have been brought down to $79,000. So anyway, the last two, a brain cancer and lumbar spinal fusion, just really tough things to see out there, and we hope that those folks are doing okay. But we do feel like it's important that you all do see that the plan is certainly impacted by some of these large claims. COVID, I don't know that we're still on successes. I think we're more in plan and reporting, but the COVID reporting through the end of July here, the total treatment costs so far with COVID has been $2.6 million in direct costs related to COVID. The number of divisions or bank locations in Advanced Health Plans that have had COVID claims is 183. That's most all of us. When you look at the treatment details where you see COVID-19 confirmed 1.3 million and COVID-19 suspected of 1,063,000, really you just add those two together, because a COVID-19 suspected claim is simply a claim that comes in where COVID is not the primary diagnosis. It's going to be the secondary or the third or the fourth or the fifth diagnosis down. That would be a situation where maybe somebody presented at the emergency room in respiratory distress. Doc, I'm having a hard time breathing. And then after they put you on oxygen, check you out, run a COVID test, the next morning they find out, oh, lo and behold, you do have COVID. And by then, you've already got a page full of charges from the hospital. That would be a COVID-19 suspected. A COVID-19 confirmed would be where you were feeling kind of cruddy and you went and had a COVID test, you had COVID, and then you end up going to the doctor. So that's, again, for all intents and purposes, they are the same thing. The antibody testing and COVID testing, those numbers are dramatically understated, because we've seen a tremendous amount. I know we've seen it just at the Kempton Group, a lot of antibody testing and diagnostic testing that folks have just paying out of their pocket, or they're going to some sort of a medical provider, maybe it's a county or state health department, and they're getting these things for no out-of-pocket costs. If there's no out-of-pocket, we don't see a claim, we're not able to tally it. Any questions on any of this reporting? I was hoping that we weren't even going to have to talk about COVID this year, but every time I watch the news and I see how many folks are Oklahomans and Texans that are actually in the hospital right now, I can't help but think I hope none of those are bankers. But we probably all know that there are bound to be some bankers impacted. This is the last COVID report here, just kind of shows us that the top half up here is our COVID claims by volume from April of 2020 to July of 2021. The two worst claim months in the history of Advanced Health Plans were July, from a dollars perspective, were July of 2020 and January of 2021. We see the little spike in October, but that's from a volume perspective and just didn't translate to big dollars at that point. Prescription experience. This is one of our internal charts I thought would be useful for our bankers. Our board members that are here also will recognize this chart from a monthly report package that they get. But it does show the average prescription cost per employee enrolled in Advanced Health Plans. We did make, if you all will recall, last year when we did this user group meeting, we introduced the pharmacy benefit manager changing from Script Care to Southern Scripts. That went effective January of 2021, right here. You can see from the chart that we have seen a pretty significant, meaningful reduction in overall RX spend. We've gotten a few phone calls where members have experienced, I think the right word would be disruption. I'm not sure, where there were a question that arose out of the prescription program. And I think Melissa and I mentioned at the last user group meeting that we will probably hear more in the HR departments of our institutions where some employee is talking about, well, I've got a problem with my prescription. They're asking questions or they didn't approve it or whatever else. And I think we warned everybody that one of the reasons we were moving away from script care to Southern Scripts is because script care, they were very easy to get along with because they didn't look at anything. They didn't stop high dollar prescriptions. They did not check for clinical appropriateness, et cetera. Of course, when that happens, it's hard to find fault in them as long as you're okay with the cost continuing to go up. So the move to Southern Scripts, we knew that they were more aggressive than script care as far as, again, right sizing those prescriptions, making sure that they were the right drug for the right patient at the right time. They have been true to their word, and I feel that they've struck a good balance. They have been very communicative when a prescription has been stopped because of a prior authorization requirement. They are working with the patient and the patient's physician to provide the clinical rationale why this drug is the right drug at this particular time, and it's been impactful in a good way. Other things I want to kind of point out on this slide. If you look down here, can you all see? Yeah, you see my cursor. VCP, that stands for variable copay. That was another reason why we made the move to Southern Scripts, is they do a very, very good job of capturing more completely the available manufacturer's copay assistance. And maximizing it not only for the member, but also maximizing it for the plan. So far in the first 7 months of 2021, the Southern Scripts has captured about $171,000 worth of plan, of dollars that would have left the plan that actually was savings that came directly from the drug manufacturers. The only thing that the employees had to do is, instead of getting that prescription from a particular mail order prescription house, they actually did have to move to CRX, which is Southern Scripts' partner for certain specialty drugs. We did have a handful of participants that and this was unfortunate, but we had to switch from a local pharmacy to a mail order specialty pharmacy. Number of those switches has been, I believe it's been within like 10. It's been pretty small. Again, it wasn't done for nothing. It's going to end up being, close to $250,000 a year that would have been spent that was ended up being saved. The last thing that we'll be picking up later on in the presentation to talk more about is, and this is one of those statistics that really, you see a lot of eyes just widen. But what this little blurb down here is talking about the cost of specialty medications. Do we remember what a specialty drug is? A lot of us, we hear about biotech drugs or specialty drugs. A lot of times they're injectables. People have always said, Jay, give me a definition of a specialty drug. And I was like, well, I wish I could. I know them when I see them, but it is a very loose definition. It is essentially our high dollar drugs that are limited distribution. They are growing in popularity. They're growing in availability. And a lot of these drugs are miracle drugs. These are drugs that change people's life. They allow people to stay at work, where if they didn't have the drug, they would either be in the hospital or they wouldn't be able to work. So there's no question that these are those miracle drugs that we all hear about. But like everything else, there comes a price for that. And so what this statistic down here is showing us is that the specialty percentage, this is number of specialty medicines versus the total prescriptions that we buy as a trust. 0.9% of all drugs that are purchased by our members in advanced health plans, 0.9% of them are specialty drugs. Just 0.9. However, specialty drugs as a percentage of the plan spend for drugs is 48%. So 0.9% of drugs that we buy that are specialty represent almost half of the total prescription spend of advanced health plans. Just think about that. I can boil it down one step further. That 47.9% of the spend and the 0.9% of the total RX number of prescriptions, that boils down to about 50 members. When I say members, it may not be an employee, it might be a spouse, might be a dependent, but there are roughly 50 individuals that, again, are taking drugs that have changed their lives for the better, that has meant the difference between sometimes being disabled and being able to actually work. But they do represent almost half of our total prescription spend, which I also mentioned earlier. If you remember, about 30% of the total spend of advanced health plans, about 30% of it is prescriptions. So anyway, anything that we can do to improve the ability to buy these specialty drugs at a lower price point is something that, as you can probably tell, as a board, this board of trustees just can't ignore that. It's always, something that affects a very small number of people, but it has a huge impact. And so there is a strategy that we're going to talk about here in a little bit that'll talk about that. But again, I thought that would be a real eye opener. Scripta Insights. Through a show of hands, I wish we could see some of the remote users, because I can't see your hands, that's for sure. But in the room, we have an awareness of Scripta Insights. We get our purple dot savings texts and emails. The results of Scripta Insights, we've been doing that since, what was it?
October 2019, I believe.
Yeah. And it was a slow ramp up. COVID slowed everything down. But in the first quarter of 2021, Scripta had assisted really 61, these are actually 61 drugs that the patient voluntarily switched from a particular drug that they were taking to a higher value drug that was also clinically appropriate. They did that through the information that Scripta had made them aware of. That resulted in 61 switches in the first quarter and in 162 switches in quarter two. Yes?
Are those switches, are they coordinated through the physician also?
Yes, absolutely. Unless it's a generic. Of course, if you're moving from a name brand to a generic, the pharmacy can actually make that switch. They don't even have to tell the patient. But not all of these switches are from name brand to generics. Some of these are from one name brand to another name brand. That would require physician approval. Yeah, great question though. Plan savings of $88,000 so far in 2021. The Scripta fees of almost $72,000 eked out an ROI of about 1.8. I can tell you that we'll be talking with Scripta in the future. We'd like to see that number improve. We do have an agreement in place with Scripta Insights where the plan will never, they'll actually eat their fees and reduce their fees if they're not paying for themselves and then some. Being that they're at 1.8, to me, that's a little skinny. I'd like to see some more return out there, but we're still in positive territory. Of course, when we look at VASA Health over there, it was 33 to 1 on the ROI. That means either one or two things. We're getting a heck of a deal, or they're going to raise our rate. But any questions on Scripta? Anything negative about Scripta?
We had an employee that switched medicines, and they were very leery of it, and it's worked great. So
Awesome.
They started taking new medicine, and it's working at least as well as the other ones.
Yeah, that's great. That's great to hear. It's a very interesting. You start talking about people that are switching from the green pill to the pink pill. That people get very, very proprietary about a particular drug, and sometimes you can tell it's the same drug. It's an equivalent drug. It's a therapeutic alternative, meaning it's essentially the same drug. It's just lower cost. Boy, some folks they'll dig their toes in on that, and I think they underestimate the marketing dollars and research that are expended by the drug manufacturers to drive that brand loyalty, and they're very successful with it. Okay, everybody's been waiting for this slide, I know. I can tell you that the board, we've had, and we do have quarterly board meetings. I think we've had at least 2 off-quarter board meetings just because of COVID. Obviously, we had a off anniversary rate adjustment. Again, I think we talked to every banker in the program about the rationale behind that. I know the bankers that I spoke with personally, I tried to explain the rationale there. It wasn't so much that the losses were so large. It was the rate, the burn rate, that really spooked the board and really spooked us as the plan administrator. When you see within the span of just a few months, almost $3 million that your actuary did not anticipate just evaporating. You look at a burn rate like that, and you thought, my goodness, we may not have time to react if this doesn't start to slow down. That's always the situation that the board is in, is you never know if something good is happening. Is this a fluke, or is this the beginning of a great trend? Likewise, when things bad happen, is this a one-off bad month, or is this the beginning of a trend? So with that being said, the trustees looked at a lot of things this year. A lot of things were discussed. We've had a couple of board meetings that are 2 and 3 hours at a shot. Like to have killed the board, I think, a couple of months ago with so many things being talked about. And a lot of the things that were being talked about were pretty complex. But they did an amazing job. They represented the banks very, very well. Just a few of the things that, before we get to the actual rate adjustment for January, some of the things that were discussed and were looked at. One of the things that came from the actuary, didn't come from us, didn't come from the board, but actually came from the actuary, was, have you all ever considered just not renewing, not offering a renewal to banks that are chronically poor performing? So banks that have a loss ratio, or the dollars that they send into advanced health plans in the form of contributions versus the dollars that the trust pays back out in claims, if that's upside down for the last 5, 6, 7 years, even though they get a larger increase because they get a bucket shift, we all know what that means, but even with that, they're still in the red. Have you all ever considered just non-renewing those banks? And that was, I think we've talked about that in previous meetings, that idea had been floated. I want you to know that your board did not take that as a decision. They didn't take it lightly at all, because it really kind of changes the complexity, not the complexity, it changes the culture really of advantage? Are we all in this together? Are we here sharing risk? Or are we going to say, well, you're too risky, so we're going to vote you off the island? I think human nature looks at that and says, well, as long as it's some other person, I'm okay with it. But next thing you know, it could end up being your bank. And so ultimately that was discussed. It was not approved as a strategy. There were 3 banks that the trust actuary identified as being in that category. But at the end of the day, when you looked at them, if those 3 banks were non-renewed, voted off the island, if you will, it would have benefited the remaining banks less than 1 percentage point of rate. And so the decision was made at that point. That could be me next year. So we're going to keep the big tent. That's probably going to be something that the board will continue to look at in the future. But I did want to at least share with everybody that was something that was discussed, was not approved. The next strategy that did come from the Kempton Group, not as a recommendation, but more of I think it's time to look at this, and that is, what if we were to move to full reference-based pricing? We've talked about it in this room before, many times before, about the financial impact to the trust. I think it's close to 20% reduction in expected claims. But obviously there are a lot of banks that are simply not ready from a cultural standpoint to do this. The board felt that even though there was a substantial monetary benefit to the trust, that it was just a bridge too far. They were not comfortable with it at this point in time. And that, again, is exactly what that board is supposed to do, is look at it through the eyes of the members. Yes, AB.
On the reference-based pricing metrics that you went over, am I reading this right? We had over 17,000 total claims. Of those 17,000, you had 20 that were balance bills. 14 of those 20 were resolved positively. And that resulted in 6 out of the 17,000 that did get a balance bill.
Yes.
That's 0.036%.
Yes. Now, you never know about the thing that was not in that report. Is you don't know if that balance bill was $500, then the trustees have said, for $500, let's make that go away. As long as it's not crazy. As long as the hospital's not wanting 2,000% of Medicare. But there are some of those claims, and this I think, I'm not going to put words in the board's mouth, but some of those unresolved claims, they could end up being, it could be $50,000 that gets balance billed to the patient, and you could end up with a hospital that has drawn a line in the sand and they want full billed charges, and full billed charges is 873% above Medicare. So we're at an impasse. I'm not authorized to go crazy and meet the hospital in crazy land and spend those kind of dollars. But then if they're not willing to budge either, again, we're at an impasse. And so even though it's a small number, if it's you, if it's your spouse, if it's your CEO, if it's your brand new teller, that could put somebody into bankruptcy. And again, it's something that is continually discussed. It is a low risk, but there is risk. Great question, though. So that was not approved. That did not pass. The 3 things that did pass, though, approved that the Oklahoma member banks, whenever possible, and we are going to have the analysis is being done for every single one of the Oklahoma member banks to make a move from whatever PPO network you're currently on to the Healthcare Highways network. The analysis that's being done is what type of disruption might you see? Is there 3 doctors in your community that are not part of Healthcare Highways? Is it a hospital? Is it, or is there really no disruption because there's perfect overlap? Those things are being done right now. And if we have a situation in which the healthcare highways network is just flat out not compatible because there's just too much of a mismatch, that might be one where we do have the discretion where that particular bank may not have to move this year. That would be something that we would have to work with healthcare highways or even maybe do some direct contracting. There may be direct contracting opportunities within that area. But for banks in Oklahoma, in which it is a very generous overlap, 90+% potentially, those are going to be ones in which those banks you'll be, somebody from the KPP group will be coming out talking with you about that, either in person or remote. And then with plenty of time, hopefully we can get out there and do an employee meeting to talk to you about the impact and how that would look to your employees' independence. There'll be more slides on that, but again, that was approved, and I'll show you the dollar impact to the trust. The other thing that was approved by the board, lots of things were discussed here. They also approved no negative bucket shifts for 2022. So what that means is if a bank is more risky and they are going to get what we call a positive bucket shift. Positive does not mean positive as in good. Positive means in an increase. If your bank is slotted for a positive bucket shift, then you're going to get it. The Kempton Group is on Advantage Health Plans. We're getting a positive bucket shift this year. First one in several years. We've had some large claims. But if your bank was set to improve a risk category, then you're going to freeze where you're at now and just get the trust level increase. That was done for a particular reason. That for a bank to move down, for several banks to move down, what that ends up doing is, yes, it does help that particular bank, but it ultimately increases that baseline increase for all banks. What they're thinking about is we want to keep our powder dry. COVID is very scary still right now. We saw what it did to us. We want to be on a trajectory where we can have the lowest increase possible, but we do need to have enough surplus generated where we can start building back some of that surplus. We enjoyed a tremendously high surplus in 2018. Almost $14 million in net assets available for benefits, which was double what the actuary recommended, more than double what the state of Texas and the state of Oklahoma required. A lot of that has been burnt off. And so we want to get back on a trajectory where, again, we're going to be able to be safe, secure, and start building a reserve. One of the ways of doing that without just increasing the rate for everybody is, again, to freeze those negative bucket shifts. It's not that we're departing from the concept of rewarding good performing banks. It's more of okay, we're going to lock arms together until we kind of get our surplus built back up, wait till we hopefully can get COVID in the rear view mirror. So I hope that the banks agree with that approach. We felt like that was the right approach, but that was an approach that there was a lot of discussion and a lot of debate by the board on that. The last thing on here before we get to the number, this was something that we're going to be talking more about this next year. And when I mean next year, I mean starting in January, February. It's going to be kind of a 12-month conversation. So Melissa and me and our teams will be talking a lot with the banks about this. But what was approved by the board was if your bank was slotted for a positive bucket shift because your bank is more risky this coming year than you were last year, so you're going to be moving up a bucket. It was also approved for banks in that category, and again, we're in that category, unfortunately, is that we are not going to be able to change the plans that we offer to our member banks or to our members. So if a particular bank is offering 3 particular plans right now, and that bank is slotted for a bucket shift because they're more risky. They have poor performance from a financial perspective. Then those 3 plans that they are offering will be the same 3 plans that you'll have to be offering in 2022. Hope that makes sense. Paul, you want to say something?
What about the ability of the bank to change its base plan for its employees, not just
Yeah, that's behind the scenes as far as we're concerned, as far as what you want to incentivize from a contribution perspective. In other words, if you want one particular plan to be the lowest cost in your bank because of the way that you share the expense with your employee, that's up to the individual bank. Yeah. That's behind the scenes as far as the plan's concerned. Yeah, so that particular question was, what about an individual bank that is in that category? If that particular bank wanted to help me out here, but reprioritize the plan that you offer as far as how you share the cost with the individual employee. For instance, Kempton, we incentivize folks to take a choice plan through the contributions. If we wanted to de-emphasize choice plans and start paying more for a different type of plan design, we could certainly do that, but that'd be a function of the individual employer.
Yeah.
Did I say that right? Okay. Thank you. Yeah.
If we were able to see a positive bucket shift, can we reduce the plan choices that we have?
Reduce the plan choices. So you're offering 3, drop 1?
That's what they're asking, yes.
So there were no
limitations that at this time there were no limitations placed on the banks that were in the category of not going to a worse bucket. The limitations that were placed on the banks that were only moving to a worse bucket.
To a worse bucket, yeah.
So changing plan designs should be within the accepted plan changes that were allowed for those banks.
The thing that bank mentioned, though, that if they're getting a positive bucket shift, right?
Yeah.
So a positive bucket shift, again, is a bad thing. A positive bucket shift is that you're moving to a more costly risk category. So if you are in that category, then you wouldn't be able to add any additional plans, but I don't think there would be any moratorium on them dropping a plan.
Yeah, we probably just have to look at that. I think the consideration would be if somebody is offering a base and a buy-up plan, so they're offering 2 plans and they're moving
Right.
to a positive risk category, they're moving to a worse risk category. And so if they dropped the highest plan, the most rich plan, and then more utilization moved down to more membership, more enrollment moved down to the least expensive plan, that would probably fall into the category of what Milliman
Was trying
discussed.
to
Avoid.
stop happening. Yeah.
Right. So probably need to discuss that further.
Yeah, we'll need to discuss that further. Reagan, if you could get the name of that banker, we'll get back with them on that. So as Melissa just mentioned, she mentioned Milliman. Milliman is the trust's actuary at this time. One of the things that they continue to highlight that has gotten to a point in which it's going to have to start being addressed, but it's going to be addressed over a period of years, is that when there's a trust level increase, say let's say a 5% increase at the trust level, and then banks migrate to less costly plans, for instance, because we offer 14 different plans right now. Migrate to a less costly plan. Well, that bank can, and many times does very successfully, they may completely negate that 5% increase and may actually at the end of the renewal process, even though the Advanced Health Plans Trust had a 5% increase, because of plan migration to lower cost plan offerings within Advantage Health Plans, they may actually be paying the next year less than what they were paying the year before. And so and this is where it gets very complex very, very quickly. But from an actuarial standpoint, what you end up with is the trust needs 5% more contributions. And then when the banks end up doing their migration, instead of a 5% increase, the trust actually receives maybe 3% less money than it had before it needed the 5% increase. So we didn't move in the right direction. We actually lost ground. Now, that's not the fault of bankers, but because bankers are doing what any good business owner or manager would do, and that is trying to find the best possible benefits at the lowest possible price. But what that does is it creates risk shifts within Advantage Health plans. And when the actuary set the pricing of a particular plan design, a lower cost plan design, they all use actuarial math. That's what we like to call it in the board. They look at the what they expect the claims to be for an individual employee that would migrate to, say, a $5,000 deductible plan. And they have an expectation of the types of individuals, the type of risk that would take a higher deductible plan at a lower price. And some of their assumptions have been incorrect with our bankers, because they would assume, well, if a bank's going to offer a $5,000 deductible plan, the only people that are going to take the $5,000 deductible plan are the young, healthy employees within the bank. All the older folks that have got some health conditions, they're going to stay on a rich plan. But what we've actually seen is most of the bank would move to that lower cost plan. Well, that plan was not priced originally assuming that all these really risky individuals would be in that plan. And so what you end up with is, with some of those plans, now those plans are underpriced in relation to the lower deductible plans. And so the board has gotten a crash course on plan relativities. And it's about made all of our heads explode. But one of the ways that we can address that in the short term, again, this is something that we didn't, the issue with plan relativities and imbalance, it didn't happen in a year. It happened over several years. And it's going to have to be addressed over several years. But one of the ways to mitigate the impact of that, again, is by slowing this plan migration down some. And so that was the decision that was made for 2022. I hope that makes some sense. If an individual bank wants to discuss it more in depth, we're certainly not going to be able to do it right here in the next 30 minutes. But it would be something that we would really appreciate the time to sit down with you at your bank or remotely and discuss this in greater detail.
And Jay, and everybody, the renewal letters that get printed, they are going to look a little bit different this year because they will be a little more customized to what your specific options are based on the category that you're in, the risk category that you're moving to, and then the plan designs that you currently offer. So some of those questions will be answered by virtue of receipt of the renewal letter, because we're trying to be a little bit more specific and customized in that letter. But yeah, I agree with Jay. We can definitely have those conversations and help you through what that strategy looks like.
Now, so these last three bullets, these three things that were approved by the board, every single one of those had a credit sitting next to it, as far as that would help buy down the overall trust level increase that we all pay. And so without further ado, the 2022 January 1 adjustment trust levels 3.5%. Now that number wasn't 3.5% without the three changes that we saw over there. It was higher. It was higher. And so it's that balance between trying to being run by bankers, being able to watch the dollars that leave the bank that end up going to the health plan, versus trying to maintain a good quality benefit plan. And so that balance, I feel like, was achieved through the trustees looking at all of the options out there. Now with this 3.5, it is expected not only to cover anticipated claim obligations for the plan year of 2022, but also to build a surplus, put us on the trajectory of building back the surplus that was lost. 65% of the member banks will be receiving that trust level increase of 3.5%. About 35% will be getting that positive bucket shift. And as we've talked about before, depending on which plans you're on and what bucket, what risk category you're in now, some of those risk categories, if you get a positive bucket shift, it can be 3 or 4%. And then some of those shifts can be of higher value, where it can be, 8, 9, 10%. That information will be delivered to the banks by October 1. Okay. Any questions, comments on that? I do look at this, I'm kind of glad we did the 8% when we did, quite honestly, because undoubtedly this would be higher if we hadn't have done that. I know it was certainly not something that we want to get in the habit of doing. I think in 40 years of operation, it's happened twice. Hopefully it'll be Isabel's problem by the time it happens next time, if it ever happens again, assuming she doesn't go off somewhere else someday. Okay. Historical rate adjustments. Again, this gets back. I wish now I'm looking at this. I wish we kind of had that net increase number that I had talked about, but it does kind of stick in my head that in 2021, January of 2021, when we had that 10.6, I do believe that was and any board members, y'all have better memory than I think that was the number where we ended up actually coming out with a net negative. I think it was like a -1, -2. So you have a 10.6% increase, but the net to the trust was actually a slightly negative number because of all of the planned migration. So again, when you end up with $3 million worth of unforeseen COVID claims, you end up with an imbalance. Now I've noticed that I've gone through all of this heavy lifting, and the next slide is Melissa's.
So good news. For those of you who offer our ancillary benefits, and so under the category of ancillary, we include our dental plan, a vision plan that we offer through VSP, and then also a combination of some additional life insurance products and disability products. We're not experiencing a change for the effective date, January 1st, 2022. Some of that is because, and we talked about this last year, some of that is because on the ancillary products, more often than not, they actually come in multi-year rate guarantees. So rather than even going through a renewal every year, they go through like a 3 or 4 year cycle. And that is the case on some. On others, though, like dental, for example, the dental plan does go through a renewal process the same way as the medical plan does every year. And one of the things that was taken into consideration this year for the purposes of a renewal calculation, there's always sort of a balance that the trustees have to strike between a couple of different things. One, what is the market in dental services? And so what does that mean? We're looking at on a regular basis, what are the billed charges for the claims that we're receiving on the dental plan? And we're sort of indexing those against other sources. Like, for example, we use, you all I think are familiar with this, the way that the dental plan works, there's not an actual network on the dental plan. So there's not a pre-negotiated allowable with a set number of providers for what they're going to accept as an allowable under the plan for their services. So it's not a network plan. However, the plan does reference something called usual and customary, and they also set a scheduled amount, which is basically a fee schedule that says, here's what's going to be covered for these different services on the dental plan. So that's looked at regularly, and we're sort of looking at what are the charges that are coming in, and that's kind of how you check the market and balance that against what is that usual and customary rate. You can probably guess that under the usual and customary, there is a measure of inflation that occurs on an annual basis. So we typically see that usual and customary rate increase annually. But that's not the only thing that the trustees take a look at when determining how to make changes on the dental plan or whether to make changes on the dental plan. The other two factors that they consider are what I kind of put under the category of member experience, which means no matter what the dentist charged, no matter what the billed charges were, whatever the rate that was paid under the plan, did the member experience any disruption as a result of getting a balanced bill for the difference in those two numbers? We kind of put that in the member experience category. So we're sort of taking feedback on that and updating them on a regular basis and also reviewing that internally. And then the last thing that you have to balance is the price for the benefit. And so when you factor in all three of those things, the trustees were able to, and the actuary made this recommendation not to make a change to the dental plan because it appears, at least for 2022, that where the rates are set currently are enough to account for what the claims are expected to be. And even when you factor in that there has been inflation over the last several years since the last time that any of those scheduled amounts or anything was changed under the plan, there has been inflation, but at the same time, there is not a significant amount of balance billing that's happening on the dental plan. So what they decided to do is to not make a change to any of the dental allowables or the method in which is going to be used to determine what would be allowed charges under the plan, and also accept the recommendation of the actuary to keep those rates the same. So that'll be an analysis that they'll continue to go through on a regular basis, at least annually, and comb through all of that data. Please give us feedback. We don't typically hear much disruption on the dental plan. In fact, what we actually usually hear is very positive feedback on the dental plan about the coverage. There are some enhanced benefits. We kind of go out and check the market to see what's out there periodically and compare this plan against other dental plans as well. And there are some enhanced benefits on the dental plan that's being offered through Advantage Health plans in comparison to other plans. So in summary, if you're offering the ancillary products, none of those products are anticipated to change and go through a renewal this year. So the rates that you're currently paying for those will stand throughout 2022. I would just make one comment though. If you're not currently offering any of those products, if you're offering either if you're not offering a dental or vision plan at all, or if you have that with another maybe insurance carrier like a Delta Dental or an iMed, for example, we will be including in our renewal, as we do every year, what the rates for those plans are. And so take a look at that. We can actually come out and also help you with a comparison between the plans that you're currently offering and what's available under Advantage Health plans. Some of the benefits that are available through Advantage Health plans by participating in our plan is that you get to be a part of, just like on the medical plan, a bigger cohort of individuals. And so oftentimes there are things like, lower rates, better guaranteed issue amounts on the disability, improved age reduction schedules, et cetera. There's just usually some enhanced benefits that are available. So if you're not offering those, you'll get an opportunity to see what those look like, and we would definitely encourage you to take a look at whether or not that makes sense for your employer organization this year.
We'll step through now just some of the 2022 benefits, kind of also a little bit more detail on a few of the changes.
Okay, so these two changes we talk to you about every year since the passage of the Affordable Care Act, because under the Affordable Care Act, there were some regulations that went into play that mandated what the maximum out-of-pocket could be on any health plan. Our plans are compliant, and so we kind of track what those changes can be. So we offer two plans that are sort of in the category of tracking what the maximum out-of-pocket is allowed to be under the Affordable Care Act. And due to inflation, that changes every year. Those plan designs are called the minimum value plans. We're going to talk about some changes to those on another slide, but you recognize the name of those plans as the minimum value plans. Currently, there's 2 of those. One of those is called a standard plan, and it doesn't have any copays. The other plan is called a plus plan, and it has copays. So if you're offering the minimum value plan, or if you've offered it in the past, one thing that you know is that that maximum out-of-pocket goes up every year as required and as allowed under the Affordable Care Act. That is happening for 2022. So we usually announce to you all that is a change that is going to be effective on January 1st. It's not a change that we have any control over. It's a change that we comply with. And so just know that starting January 1st, 2022, the single max out of pocket is going to be $8,700, and then the family max out of pocket is $17,400. The second change that's sort of in that same category, the plan design that it affects is for our high deductible health plans. So you all probably know the high deductible health plans as the HDHP 2500 or the HDHP 5000. That's the name of the plan designs that fall into this category. Those plan designs, or that name of that plan design, should signal to you that they are qualified under the IRS requirements to be paired with a health savings account or an HSA. But there are some requirements to be counted in that qualified category. And one of those requirements is that it has to be counted as a high deductible health plan. The deductible has to be high enough. And the law tells us what that deductible has to be. So typically every year that changes, and typically you start to see that minimum deductible start to creep up a little bit. But in 2022, they actually made the decision not to make any changes to that. So the plans are going to reflect that, and there's not going to be any changes to that minimum deductible for either of those plans. This is another change that's occurring January 1st. If you kind of think back a few years, the overall plan changes or plans that we've offered, the plan selections that have always been offered, sort of changes. Some of that is a result of offering, just alternative solutions to continue to stay competitive with what the market offers. Years ago, the average deductible of a plan design that a banker was offering to their employees was $500 to $750. Now, the average deductible of a plan design that a banker is offering is somewhere in the $3,000 range. I think there's a number of reasons for that. Part of the reason for that is just over the years, we talked about it a little bit earlier. If you get a rate increase at renewal time, you sort of change what the makeup is of the plan designs you offer to try to mitigate that rate increase. That's a strategy that a lot of people use, not just in this plan, in a lot of plans. But one of the other things I would tell you is that with the advent of the enhanced benefit programs that we administer through Advantage Health Plans and with the Kempton Company, like the Kempton Premier Provider Program, you can offer plan designs that have a higher deductible because you still have the benefit of the lower deductible or an eliminated deductible with free benefits by choosing the right providers. So we have started to see that there has been an inflation or an increase in the types of plan designs that bankers are offering. But what that means is there's also a necessity for us from an administrative perspective, from an operational perspective, and then also from a cost perspective to regularly take a look at what is that combination of plans that are available and do those need to be tweaked. In prior years, you have heard us come to this meeting and talk about we have added some reference-based pricing plans, the choice plans. When the Affordable Care Act was passed and employers now had a responsibility to comply with the law to offer plans that met certain, baseline requirements that were also affordable to their employees. You saw us announce that we were providing a plan for you all to check that compliance box. That's the minimum value plans. So these plan design makeups change on a regular basis. The change that's happening now is as a result of taking a look at where is everybody enrolled? When you take all of Advantage Health Plans and all of the member banks that participate in the plan, and you look at what plan designs the bankers are offering, and then in turn you look at how many people are enrolled in those plans, there are some plans that have just devalued over time, and the number of people selecting those plans continues to get smaller and smaller and smaller. So one of the decisions that the trustees made this year is to eliminate 4 plans. We've included in the slide deck and in the handouts that you all have have the number of banks that are affected, and then also the number of members that are enrolled in those plans. So you can see here that the 4 plans that will be eliminated starting January 1st would be the Value 3500 plan, in which there are 14 members enrolled in that plan. The Choice Minimum Value Plan, so that's one of the reference-based pricing plans as well. There's 1 member enrolled in that plan. The Choice Select 500, there's nobody enrolled in that plan. And then finally, the Minimum Value Standard Plan, there's 8 members enrolled. I would mention on that plan that when we originally rolled out the Minimum Value Standard Plan, that's the plan design that is the highest deductible. There's no copays attached to it. And either a year or 2 years after we rolled out that plan, which was the one that we called the check the box plan for employers that needed the compliance solution that was very, the most affordable for their employees. When we rolled out that plan, within 1 or 2 years after that, we rolled out another plan that was the Plus plan that added copays into that plan design. And we saw a lot of employers switch over from that standard plan to that Plus plan. So you kind of got the best of both worlds. It's a high enough deductible that it is a low enough premium contribution, but it has the convenience of the copays, and you still maintain and preserve the benefits for the enhanced benefits under the KPP Free program. So that's why that migration has occurred. But those are the 4 plans that will be eliminated. I think probably, you all know kind of what the solution is that you offer to your own employees based on, the plans that you've chosen to offer. Those will also be, though, included on your renewal letter when we send that out. So you'll be able to see if you're affected by one of those particular plans that's being eliminated. And if one of the plans that you have is being eliminated, then what we need to work on is during the open enrollment period or prior to the open enrollment period, having you all make a decision about whether or not you want to just preserve the other plans that you're currently offering, if there are some, or replace one of those plans with one of the other plans that's currently offered. And so we'll talk a little bit about the timeline and when to make some of those decisions and communicate those to us so that you can do the enrollment in another slide.
Thanks, Melissa. So again, we had mentioned for Oklahoma banks only that we're going to start heavily emphasizing and trying to steer banks towards the healthcare highways plus network. This is kind of their footprint as far as network footprint. Some of the large systems and regional medical centers across the state that are represented are here on this list. Again, individual bank network analyses will be provided with Renewal on October the 1st. We do expect to have conversations with the banks and work on a kind of a multi-pronged strategy. One, assuming that there is some fallout or there's a gap between the network penetration with the current network that the bank is on versus healthcare highways. The 2-pronged approach would be to work with healthcare highways to try to fill in some of the gaps or do some direct contracting if that needs to be done. Sometimes when there's gaps in network coverage, though, because we do this, it feels like every day with other customers, a lot of times those gaps can be chiropractors. They can be physical therapists. They can be medical providers that are not the big hospital on the hill that people are really concerned with. It's what we would kind of consider ancillary providers. And if you all will remember, Advantage Health Plans, if you go to an out-of-network provider, remember there is no penalty in the plan design if you utilize an out-of-network provider. If you utilize a provider that is not contracted with Advantage Health Plans, the plan is going to pay that just like that medical provider was in-network. You're going to have the in-network deductible, you're going to have the in-network coinsurance, and the in-network out-of-pocket max. The only difference is that we're going to hold that bill to basically the reference-based pricing levels. And I would tell you that 9 times out of 10, if not almost 10 times out of 10, these ancillary providers, whether they be an individual primary care physician or a physical therapist or a chiropractor, I mean, almost 100% of the time, if they're paid on 130% of Medicare, they will gladly take that, and they're actually refreshed because now they don't have to go and join a PPO network. So even if there is some gaps out there, let's take a look at those gaps and see if there's something meaningful, or if there some of these ancillary providers, because we may not have as big of a gap in practice as we may think. Hope that makes sense. So here's what was driving that. Again, I mentioned that those three decisions that the trustees made all worked to buy down the increase down to the 3.5%. This was really one of the biggest moves. Again, this is only half the trust. This is just the Oklahoma side, not the Texas side. But even on just the Oklahoma side, and we are looking for our Texas banks a better network if one happens to occur that does not prohibit direct contracting. But for the Oklahoma book of business, we're talking about an effective network discount on the current arrangements that we have with the member banks, roughly 41% discount on average off of billed charges. Healthcare Highways takes that discount to roughly 54% off of billed charges. So what does that do to the plan's payment? Well, the current network payment for, I believe this is 2021 through July?
January 1st, 2020 through July 2021.
Okay, so a year and a half.
I believe so.
Okay, so the plan payment for the Oklahoma banks, the plan payment is $5.5 million. If we were on Healthcare Highways for that same time period, the plan's payment would be $3.5 million. That's $2 million worth of just found money, essentially, utilizing the same medical providers. The patient responsibility, if we start looking at patient deductibles and co-insurance and co-pays, based on the actual claims data, through the current network, the patient responsibility combines roughly 1.8 million. That would be reduced to roughly 1.6 million. So there is a component that it actually saves the individual patients additional dollars. Now, as far as actual network penetration based on our banks and where our folks are actually utilizing medical providers, the current network, 88.8% of the providers that our bankers use are in network with whatever the current network happens to be for the bank. 11.1 are out of network for the current network. With Healthcare Highways, it goes from the 88.8 to 86.6. Non-participating providers goes from 11% to 13%. Again, I got to remind everybody, we anticipated this. That's why we changed the plan design several years ago, where we do not punish or provide a penalty if a member goes out of network. As long as that out-of-network provider is not gouging the plan will treat that out-of-network provider like an in-network provider. So again, for roughly $2 million, we trade 2% network disruption. It was kind of a no-brainer. If there are any, like I said, if there are any gaps, we have strategies to help close those gaps and mitigate any problems. So again, if you're concerned about this, please be in touch and we can come out and see you. But we think that the disruption is going to be very, very manageable. Melissa, you want to talk real quick about the Green Rewards program?
Oh, sure. So I mentioned earlier that we talk a little bit about this, and in the interest of time, I'll be brief. We have been integrated with Healthcare Bluebook as a resource for you all and for your members for a number of years, at least 8 years and maybe 10 years. And the purpose of Healthcare Bluebook is to provide a search tool very similar to Kelley Bluebook. If you're not sure what the fair market value of a car is in your geographic region, based on what the condition of the car is, then you can log on to Kelley Bluebook and get an idea of what that is. Healthcare Bluebook works much in the same way, but instead of being for car values, it's for medical services and procedures values. So there is an incentive from the participant standpoint to always utilize Healthcare Bluebook or a tool like it to be price aware about what the effect of having medical procedures in their community, in their geographic area is going to have on their benefit. And obviously, the more costly a procedure, that ultimately ends up impacting the member from their out-of-pocket perspective as well. So the procedure costs more, you end up paying more. That's kind of how that works. Procedure costs less, you end up paying less. So that is a tool to help give that price awareness in the fingertips of the participant. A number of years after we implemented with Healthcare Bluebook, we added a program called the Green Rewards. And so what that allowed us to do is to not only provide the education awareness and the tool at their fingertips, but then also provide a reward or an incentive for participants to then navigate to providers that charge fair prices or reasonable prices in their community.
And have superior outcomes as well, because Healthcare Bluebook does layer in Medicare quality data into their green, yellow, red navigation tool.
And so we added the Green Rewards program. So there were a handful of procedures that if you utilized Healthcare Bluebook and you ended up having a medical procedure like a colonoscopy or a cataract surgery, those were on the list. And you did that utilizing a green provider, then you actually got a green reward or cash paid back to you. And so that was an incentive. Last year, what we did is significantly increased. So starting January 1st, 2021, we significantly increased the number of procedures that were eligible for that green reward under the program. And it went from just a handful of procedures to several pages of procedures. The piece, though, that we did not spend enough time talking about and making sure that everybody was educated about is that there were sort of two components to this change. The first was that we were significantly increasing the number of procedures for which you could receive a reward. And also the amount of the reward, the amount of the cash reward that you would get back also significantly increased. Previously, I think the highest dollar value for the reward was like $200. I think the highest value now is like $1,500. So there is some real incentive here to be price aware and utilize this tool. However, the thing that we probably did not spend enough time talking about was what we call an engagement piece. So prior to January 1st, 2021, a member could just happen to go to a medical provider that just happened to be a green provider without doing any work. It's possible without using Healthcare Bluebook. That's just the provider that they chose, and they would get paid that reward. But post January 1st, 2021, there is what's called this engagement piece. The engagement piece means that you want to tie the behavior together with the reward. And so what is the behavior that you need to do to get the reward? Well, the behavior is the search. And so we have sent a couple of emails out recently with education about this particular change to more clearly emphasize the engagement piece, which requires, in order to get paid the reward, you've got to have the corresponding behavior attached, which means go into the search tool, utilize the search tool to search for that procedure. And if you do that pre-date of service, then that's the catalyst that they're looking for, that we're looking for to be able to pay that reward. So we've evolved a little bit as well. And our team, and I mentioned this a little bit earlier, our team, rather than using our Healthcare Bluebook search tools, since we're engaging with your members on a regular basis in our call center, we're helping to that end as well, because we're now using the member search tool, logging in with their credentials so that when they call our office, they're going through the same motion. It's just that they have the concierge person on the other end of the phone that's helping them through that process. So that is something that we want to make sure and emphasize. This year, we want to emphasize that at open enrollment and make sure that everybody kind of starts getting in the habit of using that tool and also still engaging with us so that we can help them engage with that tool so that they can take full advantage of what the rewards are that are available.
Yeah, and these rewards, I mean, probably goes without saying, but I'll mention it anyway. You know, these rewards are just a direct cost for advanced health plans. So when we get a bill at the end of a quarter for all of the rewards, and of course, you know, we want to all, you know, this we wanted to move away from this just being kind of a haphazard windfall for bankers and start to drive more behavior. And to do that, you know, as Melissa mentioned, not only increasing the dollar of the reward, but increasing the number of high dollar procedures that have huge variability, adding those high cost variability, adding those to the list, we did need to tie that to behavior modification. And so, but I think it's a genius idea, though, that our call center is actually utilizing the credentials of the caller. Hey, can I have your login information for Healthcare Bluebook? And then we will log in on their behalf while they're on the phone with us. So if they go ahead and utilize the services of a green provider, that participant will get the recognition and will get the reward, even though they didn't have to do the search on their own. They kind of had a tour guide that guided them through the search. They don't have to call us, though. They can go and log in on their own. But Healthcare Bluebook is going to key off of the credentials that were used during the login, and then marry that up with the claims data to make the reward happen. Okay, real quick, we're kind of out of time. We always run out of time. We so apologize. There's just a lot, and we want it to be as clear as possible. KPP Free, you all know how to utilize this. This is really probably one of the easiest slides. You can print this, hand it in the break room. We also have quite a few of our sample educational materials that are in your booklet. One of the tools that is not utilized, we see pockets of utilization, and so I think it's where we end up with a bank, where maybe there's a thought leader within the bank that really spreads the word within the lunchroom. But there is an app now for being able to do procedure searches for KPP. It's located in the App Store or the Android store. It's called Coral Healthcare. It's very important that you actually search for Coral Healthcare. If you search for Coral, it will take you to an unfortunate app that's not used for healthcare. Well, a certain type of healthcare, but not the healthcare that we're talking about. So search for Coral Healthcare in the App Store. It's free. You can find procedures. You can engage with a Kempton Care Advocate through the app, and then also if you engage with the Care Advocate through the app and receive a voucher, you can actually get. Looks like one of the audience's attendees has searched it. Funny, right? Who'd have thunk it? But anyway, you can also receive your voucher electronically through the app. So last time I had to have an MRI, being the CEO, I was like, okay, I'm going to try this app thing. And I sat there at my desk and did from the very beginning, engage with my Care Advocate all through the app. And once that process was done, I actually received the voucher in the app, took it to my KPP provider at the time of the service, showed him my app, away they went. And so it worked wonderful. So again, that's available out there. We've already talked about Kempton Direct Access providers. This slide kind of talks about how it works. Really the big one that I wanted to talk about before we kind of get to the end here is script sourcing. We talked about the specialty drugs, right? We talked about that 48% of our total spend is 50 participants. Well, we do have a solution that we're going to try out on this. If you are not one of the 50 members, you don't need to know about this because you're never going to interface with this particular program. It's effective October 1. It is provided through a vendor known as Script Sourcing. What Script Sourcing does is they identify these members, they outreach to the members, they gather personal financial information from that member with their approval, and then they will see whether or not that member is eligible for any drug manufacturer assistance program. So when we watch TV and we hear, pick the drug that's on TV at night and it says, if you can't afford your medication, you may, call us and we may be able to help you. That's manufacturer's assistance, and it goes beyond copay assistance. If the member actually makes within a certain financial strata and they are eligible for a manufacturer's assistance, they may actually be able to get enrolled in a program directly with the drug manufacturer, not through a generic or anything else, but through the actual maker of the drug, where they may be able to get that drug at zero cost. And it's not just zero cost to the member. It is zero cost to the member, but it's also zero cost to Advantage Health plans. So what we're hoping we can do is, if you're an individual and you make too much money, or for whatever reason you don't qualify for one of these manufacturer's assistance programs, you're going to get your drug just like you always did. You won't see a change at all. If you do qualify, the only change that the member is going to see is, instead of getting the drug from CRX Specialty Pharmacy, they may be getting it directly from Pfizer. Still come through the mail like it did before. It's just it'll be there at zero cost to the member, zero cost to the plan. Depending on how many of our bankers qualify for that program, it just depends on who's taking the drugs. I mean, are we talking about bank presidents, or are we talking about other, folks that don't make the same kind of money? Depending on how many qualify, that has the ability to save the trust about $700,000, almost $800,000. Again, by simply taking advantage of dollars that are already out there. So again, kind of a no-brainer. If any of you have questions about how the program works, then please give us a holler. It's not something that we're going to spend a ton of time on. If it's only affecting 50 individuals, the chances are high that you may end up in your bank, you don't even have somebody that fits this criteria. Any questions on that? Okay. Compliance. One of the things that's going to happen in conjunction with open enrollment, and we are going to have another webinar on this between today and open enrollment, is the trust's attorney, Corey Zavada. She owns a law firm called Fiduciary Risk Management. She is highly recommending, as is our actuary, a dependent audit to be done on Advantage Health plans to make sure that all of the dependents that are on Advantage Health plans are actually eligible to be on Advantage Health plans. There's a lot of dynamics within families these days, and it is not unheard of, to where somebody gets a divorce and they don't even tell the bank. And so if the bank doesn't know, they're not able to tell us. And so you could end up having a divorced spouse on the health plan that needs a lung transplant. That can be very problematic, especially if a scenario like that ends up being a claim that goes over, say, $275,000, which goes into Advantage Health Plan's reinsurance or stop loss carrier, because they look very, very closely at those claims. And they could end up saying, well, okay, prove to me that this person is still married. And of course, we're going, well, why would they even ask a silly question like that? And then lo and behold, they find out that, nope, there's actually a divorce filed in Texas for that individual, and nobody knew about it until the stop loss carrier started asking questions. If that's the case, Advantage Health Plans has no backstop for that large claim. We've never done a dependent audit. So we're due. The way this is going to be done, it's completely going to be done by fiduciary risk managers. One of the early things that's going to happen in this process, though, is that FRM is going to send out essentially, I guess, an attestation might be a good thing to call it. Essentially an attestation giving the bank an opportunity to kind of lay out what they're asking, what the risks are of having a dependent that is not on your plan, or that's not eligible to be on your plan, that is on your plan. Kind of give them all those disclaimers, and then give the bank the opportunity to say either, which we had some board members that said, hey, we were in a tight ship. I know every single one of our employees. I know every one of their dependents, and I know we're good. I know we're solid. If that's you, sign the attestation, you're done. If you're like, I don't really know, we've had a lot of growth, we're kind of dispersed, I don't know that I'm comfortable with signing this attestation. If that's the case, then it'll kind of go to the next step, and fiduciary risk managers will go ahead and start sending out their questionnaire and start gathering data from all of the dependents that are on the plan. You want to add anything on that?
Just maybe the only thing I might add to that is the intent is not, and the trustees and the administrator has spent a lot of time talking about making sure that this is not a burdensome process. That was actually a consideration that the trustees were very clear about with fiduciary risk management, and making sure that we had to balance both the HR heavy lift for getting this done and the member lift for getting this done. But we also recognize that there is a real cost impact when there is an ineligible dependent on the plan. And so we just want to go through a due diligence process to make sure that your bank, the individuals that are enrolled in the plan, and then the plan specifically are protected. So I think we've kind of come up with a process to compromise in all of those ways and still accomplish the best outcome for everybody. So hang with us as we get through it. We'll help you through it. We're trying to tie this together at open enrollment so that what you submit all happens at the same time. But we agree that since it's never happened in the history of the plan to go through this level of an effort of dependent audit, that it is necessary.
Yep. Agreed.
Let me be brief since we're coming to an end here.
Yep, we're almost done.
We offer a service for you all as a courtesy. If you need a compliance tool to assist you with any of the obligations from an employer perspective to be able to comply under the Affordable Care Act with your pay or play reporting requirements, this is for banks that are less than 50 employees, but it's also for banks that are over 50 employees. So regardless of your size, you do have an obligation to participate in this reporting requirement under the Affordable Care Act, and we can help you with that. We typically start sending out information once we get a little bit past open enrollment timeframe. So you'll usually start to see in the October, maybe early November timeframe that we'll be communicating out everything to you. But there's essentially a process that you'll need to go through to let us know, yes, you want our help as you have wanted it in the prior years, or you might have another solution. Both of those are okay with us, but we want to let you know in order for us to help you comply what our obligations are as what yours are, and the timeframes for completing that. So the information we've included in your packet in the slide deck is a couple of important deadlines. This is not the last time you'll hear about these deadlines, and also the fee disclosures for us to assist you with complying with that responsibility. I might mention just for your information, the fees that we charge for this service, the Kempton Company nor Advantage Health Plans actually makes any revenue off of this process. Everything that we are disclosing here is actually passed through, which means that the vendor that we use to enter this information into the software to assist you with filing these documents with the IRS and mailing this and getting this to your employees for that report, these are the fees that they charge. So this is not a revenue source for us. It's truly just a courtesy to assist you with complying.
Straight cost. I mentioned a AHP legal and compliance update. There are other federal mandates and changes that are coming down the pike. Some of them for January 1. It was too many items to discuss at this particular venture. And so that is going to happen October the 25th, and it'll be myself and Corey Zavada from Fiduciary Risk Managers. And she'll also have a guest speaker, which is Dr. Marty McCary. I don't know if anybody has heard of Dr. Marty McCary. He's from Johns Hopkins. He's been one of the big COVID experts on a national basis. He's actually one of the remote second opinion physicians for VASA Health. But he will be also kind of a guest speaker during this legal compliance update to talk a little bit about what's going on with COVID, answer any questions anybody has regarding vaccines or anything like that. So, and we'll also be talking about, obviously, the No Surprises Act, which is a transparency act that we're in the process of complying with, and much, much more. So we'd love to see you on October 25th. That will be a completely remote session. We mentioned AHP dedicated team. For those of y'all that are familiar with some of these individuals, the Advantage Health Plans Trust dedicated team members are Stephanie Young. I know a lot of y'all talk with Stephanie on a regular basis over in billing and admin for changes, adds, deletes, new plans, COBRA, et cetera. Also, Stacy Weekly and Tiana Ragsdale are also Kempton Care Advocates that work on only Advantage Health Plans Trust. Angela Shoemaker is the Research and Resolution Specialist for Advantage Health Plans, and then Dawn Ward is over plan building for Advantage Health Plans. One of these days we need to have like a meet and greet. Some of the ladies are not very they're not quite as outgoing as you and I, but it would be nice to do one of those. Maybe we figure out a forum to do that in the future. Open enrollment timeline. Melissa, you want to walk us through this real
Sure.
quick? This is one slide to go.
Yep, we're at the end here. So a couple of important dates for you all from now through the end of the year. So usually our timeline is once we have this meeting and we announce to you what the renewal looks like, then the very next question that you all are asking is, what does that mean for me and my bank? And that has to do with the specific risk category recalibration. And so we typically try to release the renewal letters for the individual banks very quickly after this meeting. We're targeting by October 1st. So we've still got a little bit of work to do on those, and then we'll hope to have those out in the mail to you all, and also placed on your employer portal so that you can grab those electronically very quickly. So we hope to target by October 1st for that. And then about a month later, some of the plan changes that we talked about and some of the plans that are being eliminated, we want to make sure that everybody has time to consider what your strategy is going to be for the next year. So do you need to, make a plan change or, plan for the contingency that one of your plans is being eliminated? We'd like to know what all of those changes are by November 1st. That allows us an opportunity to actually program into the system what those changes are and then open up that enrollment portal that you all will use as employers to enter the enrollment changes into the platform so that we can feed those into our system, print member ID cards, and get all of that shipped out to your members in advance of January 1st. I will make a note that some of the changes or some of the timeline does look a little bit different this year. And we haven't had this conversation yet, but you'll hear more about this in the compliance webinar that FRM does for us. And the information that is required to be printed on the ID cards is actually changing as a result of federal legislation under the No Surprises Act. You might have heard a little bit about that. And so that trickles down all the way to the actual member ID card. So we're being required to actually do a full reprint. That's a little bit bigger of an administrative process than what it is typically, because typically we just print changes. And so that's part of the reason going into this time frame, we need to make sure that we have all the changes from you, we have all the enrollments from you, and we can help you comply with the requirements under the law to meet those obligations under the No Surprises Act. You'll learn more about that in the compliance webinar. Open enrollment actually does close on December the 1st. And so whatever changes we make and whatever your employees do, we've got to make sure that those things are into our system by December 1st. And that's one of the things that actually allows us to process all of that and get those cards out the door. And then our hope is that we would have all of those cards delivered to your members so that they don't experience any interruption in coverage and can fill prescriptions at the pharmacy and use their member ID cards for their benefits effective January 1st. Again, that's not the last time you'll receive this information. We have a series of emailed communications that will be going out over the next several weeks and months to give you those same communications. And then, of course, the team that was shown on the prior slide is available to assist you through those changes if you need any assistance. And then the last thing that we just wanted to encourage you all with, we've added this to the slide deck over the last probably, I would say maybe 3 to 4 years, is a call to action. So we never come here and tell you that healthcare expenses are going down. What we're always fighting against is that every year we have something new to consider. This year we talked a lot about some of the prescription expenses that the plan is expected to and anticipated to incur. And we're just trying to continually find solutions. But what can you do to help to contribute? What you all can do, I think, is make sure that you have a solid strategy in place for what you're going to do for your renewal, and then make sure that you're communicating that strategy with your own employees in your own institution, at the very least at the end of the year through an education meeting, through an employee meeting. But we'd also like to encourage you to do that throughout the year. So we have sort of ramped up the production of some of the additional resources that we have available, particularly in COVID, when some folks are not as apt to do live meetings like this. We've got a couple of different videos that are recorded. We can do live webinars. We've got some printed material. There's just lots of resources available. So our encouragement to you is, once you make your decision, let's get on the schedule and get on your calendar to actually do an employee meeting and help you to communicate that, or be the ones that communicate that to your employees. Also, if you can send us a refreshed list of your employees' emails and phone numbers, that helps us to also communicate with them. So over 2021, I hope you experienced that we have actually ramped up what we call our communications drips. We are just continually trying to drip out information to you all that's effective for you to continue your conversations within your organizations about your health plan, so that the only opportunity that you have to do that is not just once a year at open enrollment. We want to give you the opportunity to do that throughout the year. So we actually put together an entire communication schedule that actually sends a couple of emails out at least per month, sometimes more than that, with different topical indexes of information that you can provide to your employees. If we have your employees' email addresses, we'll send those to those employees as well. But oftentimes we don't have email addresses. So we usually take this opportunity to say, do a refresh for us, let us refresh our database, and then that way we can make sure that any communications that are important we send out. Everybody will be getting a new ID card this year, as I mentioned. So start talking about that now, because sometimes when folks don't hear that message, or maybe they're just looking at two cards and not sure which one to use, we want to start having that conversation now to let everybody know you're going to get a new member ID card, because the more we talk about it, the less disruption and interruption we tend to see the next time that they go to the doctor after that happens. We don't typically see disruption at the doctor's office. Where you typically see it is at the pharmacy. So everybody just needs to know you're going to get a new card, throw away the old card, and every appointment that you have from here on out after January 1st, make sure that you give the new card to those providers.
I think every person with health insurance in the entire country is going to be getting a new ID card. So I don't think you're going to be able to get within 20 feet of a doctor's office without them saying, "Can I see your new ID card?"
And then the last thing that I would just tell you is, we are constantly looking for ways that we can enhance and improve to continue to help improve the member experience and give more information and more resources to you all. But I will tell you that the employers that have the best success with the utilization of their program, the highest redirections through Kempton Premier Provider, the best experience at renewals, the employers that have the most success in those situations are the ones that adopt what we would call a consumerism culture within their own organization. So how can you do that? We provide lots of resources. We provide lots of information, and we certainly can be there to support those educational opportunities for you. But I've had an employer that has put together a newsletter that they send on a monthly basis, and it's not just healthcare related. It's other things that they're communicating out within their organization, but there's a healthcare session. And so you could solicit success stories from employees within your bank. You could come up with a trivia question. You could utilize a scavenger hunt, going around the website on advantagehealthplans.com or even in Healthcare Bluebook and asking an employee to search for a medical procedure and tell you what the cost of that would be. There's tons of ideas. We can share ideas with you, but ultimately our encouragement to you all is that the success comes when healthcare is a conversation throughout the year, not just one time at renewal. So we want to give you that encouragement and help you to adopt those strategies within your own organization.
Great job, Melissa. We're down to it. We apologize. Like I said, we're about 30 minutes over time, but if you all have any questions or comments. Yeah.
Any questions on Bluebook? Would that go to the patient care advocate?
Yeah, thank you. Her question is on Healthcare Bluebook. If a participant's having a question about that, would they interact with our call center? And they would. So the Kempton Care Advocates can definitely assist with those searches, those procedures, and those rewards as well in the call center.
It could be a user problem with me, but the problem that I'm just, it's got a little bit of user learning curve to it, because there's any place to submit. But I noticed when I did something for myself, where I actually got the voucher and had the procedure done, was not listed in Bluebook. Is that normal?
I think you might want to talk about the Coral app versus Healthcare Bluebook.
And I downloaded the Coral, but I haven't done it yet. So, yeah, this was just something I had done a while ago, and I thought, so I looked on all the things, but it didn't pop up where I actually had it done.
Oh, really?
And that happened on two things, something last year as well. So I don't know if I'm gonna get that reward or not.
Yeah.
Yeah.
Good question. So
Great
I will
question.
tell you that we do integrate our Kempton Premier providers into Healthcare Bluebook. So if a participant is having a procedure that's eligible for a reward, and you do it at a Kempton Premier provider, then even though that benefit covers the entirety of that procedure at 100%, and so the member gets the procedure for free, you also get the benefit of having the reward. And so it's sort of like a double benefit. You don't get charged your deductible, and then you also get money back. So we do integrate that. What I can tell you though is that just as with anything, it goes through an update process. So if we are adding a Premier provider and it hasn't yet been added into the tool, it's
There could be some
possible
lag.
that there's some lag there, but we can definitely look into that and get back to you. The customer service reps can absolutely help you with hunting that answer down and getting back to you.
Okay, thank you.
Yeah, those ladies spend all day in Healthcare Bluebook, so they're very familiar with it.
Just trying to teach, our employees how to use it. I'm finding it myself a little bit of a challenge, so that's why I'm trying to get it down so I can teach them how to do it.
Absolutely. And you are accessing Healthcare Bluebook through advancedhealthplans.com.
No, I didn't have, I've got an app.
Okay.
I'm not supposed to do it that way?
Well, I just want to make sure, because Healthcare Bluebook,
Like here, this is the actual thing I'm talking about, and that's where I went. It's not, am I supposed to do it on there?
Go ahead.
no, you go. You're
So
more
there's
familiar with
there's
it.
actually two accesses with Healthcare Bluebook. Healthcare Bluebook can be accessed publicly, meaning
It has a
whether
free site.
whether
That's
somebody
probably
is
where I went.
yeah, so whether somebody's with Advantage Health Plans or not, Joe employee that's an employee of another organization could go Google Healthcare Bluebook, and it is a public access tool.
Kind of a stripped down version, but there is a free version that doesn't know anything about KPP.
That's
So
probably what I'm doing, so they're not talking to each other.
Right, so
I
one of
just
the-
missed out on two of the butts.
well, so one of the things that you've got to make sure and do, yeah, you've got to log into the app utilizing, it's not actually log in, it's tied to our eligibility. And so when you access Healthcare Bluebook, either with the app using a code, which we can give you that code, when you access Healthcare Bluebook through the app using a code, or when you navigate to Healthcare Bluebook from our website, then it's going to take you to the right spot to attach. Yeah. So let us get you, thank you for bringing this up. Let us get you just a couple of educational pieces about that have what those nuances or instructions are that would help
It
you
might have been that
navigate.
email that came, I just kind of scanned because I go, I'm already doing that, so.
Yeah, that is the key. So there's public access versus the customized access. So thank you for asking that.
Okay, I have another question about Healthcare Bluebook. And it's if I use a customer service rep to find a KPP provider, not the Healthcare Bluebook, do I still receive a green reward?
So the question would be if I use a Kempton Care Advocate to schedule a KPP procedure, and that KPP procedure is actually a green provider in Healthcare Bluebook, will I automatically get the reward? You would not actually get that reward. You would need to tell your Kempton Care Advocate that I'd like to look this up through Healthcare Bluebook. And if it happened to be a KPP, you get the reward and you get it for free. So, I mean, you would actually make money on it, but you would have to ask the Kempton Care Advocate to work through Healthcare Bluebook in order to be able to get recognized for the reward.
One other question was, Did you consider an added premium for anyone who hasn't taken the COVID-19 vaccine?
Yeah, that is a wonderful question, which we are getting a lot of. That's something that obviously there are employers that are starting to do that within the employer. They're varying the employee contribution, making it the employee have to pay more for the health program if they are non-vaxxed. That is actually has to be done properly under the context of a HIPAA compliant wellness program, very similar to how the smoking, basically non-smoker versus smoker rates can be. The Affordable Care Act put some pretty sizable guardrails that you had to stay within in order to do that. Those guardrails don't apply perfectly well to vaccinations with COVID. And so it's kind of left up to interpretation. That's actually going to be a topic that'll be discussed at the compliance webinar that'll be coming up in October. But that is a great question, one that we're dealing with right now, and we're actually waiting for a blueprint back from FRM, fiduciary risk managers, for us to be able to answer that question appropriately. But it's not, again, there are, like everything that's a good idea these days, there are federal strings attached to it to make sure that you do it their way. Anything else? Okay. Well, we appreciate everybody's attention, staying the long stayers here that are still with us at 37 minutes over, but we appreciate your attention. I would also, just in closing, really emphasize the interactivity. Melissa and I, and really the entire Kempton Group team, we work for you all. We love to have input, like the vax, non-vax premium surcharge. That's a great comment. I would also, encourage if you have any comments, reach out to one of your trustees. A banker to banker conversation is a lot of times more meaningful than a conversation with one of us. But the board is always thinking about how to make this program better. And the way that we make this program better for bankers is, I'm firmly a believer that owners know what's best for their program better than any third party. We're a third party. Taking information and direction directly from the members has always been something that we wanted more of. And so I'm just going to encourage more of that. Hopefully the board won't be too mad at me that I just did that. But I think it's important to have interactivity and really true collaboration. Okay. Well, we're going to bring it to an end. Thank y'all so much.
Thank y'all.
Appreciate your attendance.